Hello friends. In recent times, many first year students were asking for clinical case discussion because now the paper pattern has changed and increasingly the clinical cases are being asked as 6 marks questions or 10 marks questions. And they always find it difficult to answer such questions because there is not much reference material available anyways in the market, and these are not straightforward questions. So we are starting off this new section. Already we have clinical case based MCQ discussion on our YouTube channel. Aligned with that, we will discuss how to solve such question if it's of 6 mark or 10 marks question. Let's see what is in store for us in the form of this particular case. A 12-year-old boy represents with loss of appetite and fatigue. Now, first hint, whenever they give you the age of the patient, it has some implication. I mean, for example, if it's early on in life, maybe it's suggestive of some kind of congenital disease or some hereditary disorder. If it's a 6th decade of life, maybe autoimmune disease. 7th decade of life onward, it's a neurodegenerative disease, and so on and so forth. So age does give some kind of hint. Let's see what's a hint over here. Hematologic investigation in this patient revealed macrocytic anemia. Now, the second important aspect in such questions is always look for some catchphrase or key phrase. And in my experience, such catchphrase always comes in the second last statement, penultimate statement of penultimate sentence of that particular question. In this case, it is saying macrocytic anemia. It's a big hint. So we are going to revolve our thinking around the RBCs because macrocytic anemia already mentioned. And urine report indicated low molecular weight proteinuria. Now that is something unusual. Let's figure out what it means really. So defect of which of the following is the likely cause? That's the MCQ. And if it is a case asked in the first year exam, these could be the questions. What is the probable diagnosis? Explain the pathophysiology, and what would be the morphological features. When they ask the case for 10 marks, first question is the most important one generally, and the subsequent questions are mostly related to the first question. So if you have sorted the first question correctly, then the next questions would ask theory related to it, and you have by hearted the theory, so then it becomes easy. So what could be the probable diagnosis? Let's see. It must be related to the macrocytic anemia, and then pathophysiology writing would be easy. Well, for the MCQ, they have given options. Defect of which of the following is the likely cause? And the options given were megalin, cubilin or cubulin, pendrin and connexin. Let's rule out 2 of the 4 options. Look, connexin. We are aware that the connexin is involved in the formation of gap junctions in the adjacent cells, epithelial cells, or generally the adjacent cells. In this case, if the defect is related to the RBCs, probably connexin is not involved. Pendrin. You know what is pendrin? Of course you know. Pendrin is involved in the transport of iodine into the thyroid gland and the subsequent synthesis of thyroid hormone. From the data given, it doesn't appear to be a thyroid related disease. So these 2 can be ruled out, and that leaves us with the 2 options, megalin and cubilin. The answer is cubilin. So let's find out why the answer is cubilin, what is megalin and cubilin, and then we can discuss the pathophysiology of this particular defect. So megalin and cubilin, I am just clubbing the 2 because they have lots of things in common. These are large multi-ligand endocytic membrane proteins, or let's say membrane glycoproteins. Watch the word multi-ligand. Look, normally we know that if there is a receptor, it is specific for a particular ligand. that ligand will bind with that receptor only. It's quite specific. But in this case, either megalin or cubilin, they are multi-ligand types of receptors. They can identify a lot of ligands, hormones, drugs, and various other chemicals. So, multi-ligand, that's important aspect. Endocytic membrane proteins, that is, they are involved in the endocytosis of those ligands, of those chemicals. Megalin belongs to the LDL receptor family. You know, LDL receptors present in the membrane, and there is endocytosis of the LDLs into the steroid synthesizing cell. So this receptor belongs to that family, and it is also involved in endocytosis of various substances in the body. Megalin and cubilin are expressed in the epithelial cells of GIT, kidney, and various other tissues as well, brain, lungs, etc. So GIT and kidney specifically, they are involved in the endocytic uptake of many ligands. So by endocytosis, these two are involved in the endocytosis and uptake, internalization of various chemicals like lipoproteins, like vitamin binding proteins, carrier proteins, hormones, drugs, etc. So multi-ligand types of receptors. And now let's come to the crunch part, or a key part, most important part of this discussion. Before we discuss this, let me just give you a hint. It was macrocytic anemia, right? Macrocytic anemia is a morphological feature. RBCs are large. And etiologically speaking, it is megaloblastic anemia. Megaloblastic anemia, the RBCs are large, and that's how it presents in the lab investigation as macrocytic anemia. And megaloblastic anemia results from deficiency of vitamin B12 or folic acid. So, a great hint was there is possibility of vitamin B12 deficiency. Now, you know, vitamin B12 consumed in the diet, then in the stomach, there is secretion of intrinsic factor of Castle. Now, B12 and intrinsic factor, they combine, they bind, and then this complex, intrinsic factor B12 complex, goes all the way to the ileum. Why is that? Because in the ileum, there is a receptor for the absorption of this complex, or absorption of vitamin B12. And that's where our answer lies. This cubilin or cubilin, it is present in the membrane. It's a membrane glycoprotein, as we saw. And intrinsic factor B12 complex, which has traveled from the stomach all the way to the ileum, will be endocytosed and internalized after it combines with the cubilin. So now we are on track. Cubilin is involved in the absorption of intrinsic factor and vitamin B12 complex. It means it is required for the absorption of B12 from the ileum. And as we saw in the membrane, it's present, and it's going to cause endocytosis of this entire complex, and eventually the vitamin B12 will be absorbed into the blood. And therefore, the entire story goes like this. If there is a congenital defect of cubilin, if it is not present normally, then what happens is B12 absorption will be deficient, and deficiency of B12 will result in megaloblastic anemia. So that's what happens here. Megaloblastic anemia showing in the blood picture as macrocytic anemia. The only other question that remains is low molecular weight proteinuria. Why it has been mentioned? Because this cubilin is also present in the renal tubules, epithelial lining of the renal tubules. So, whatever low molecular weight proteins have got filtered, just as hormones, drugs, and other such chemicals, they will be reabsorbed once they bind with the cubilin. You can see again, this is the epithelial cell lining the renal tubule, PCT mostly, and those low molecular weight proteins will bind and then they will be reabsorbed. Now, defect of cubilin will not allow the reabsorption of these low molecular weight proteins, and they will be lost into the urine. So, that is how it was reflected in our case, low molecular weight proteinuria. Defect of cubilin resulting in macrocytic megaloblastic anemia and low molecular weight proteinuria. So, we have solved the question. Cubilin defect results in hereditary megaloblastic anemia type 1 and low molecular weight proteinuria. Now, that being said, it then becomes easy once you have diagnosed the condition, once you know what exactly has happened. Now, I am talking for the first prof students. What is the probable diagnosis? Megaloblastic anemia, or to be more precise, hereditary megaloblastic anemia type 1, and explain the pathophysiology. So, you got to discuss the entire pathophysiology. Vitamin B12 in the diet, intrinsic factor from the stomach, then this complex goes to the ileum from where it is absorbed, and B12 is required for the cell division, RBC division, and therefore in the or rather vitamin B12 required for the DNA synthesis in the RBC precursors. So B12 deficiency results in megaloblastic anemia. Then you can write, once you have by heart, you know already about megaloblastic anemia, you have by hearted it from the theory, entire thing you have to write in your answer. And what would be the morphological features? Well, we have already said there will be macrocytic anemia, and then you got to write the blood indices. For example, mean corpuscular volume, MCV, will be, you know, the range 78 to 93, 94 cubic microns. So it would be definitely more than 100, 120 cubic microns. That would be the morphological feature, important feature in the megaloblastic anemia. And apart from that, the large RBCs, etc. So that was the clinical case for the day. We will discuss such cases on a very regular basis. So it will be a good idea to subscribe to the channel and hit the bell icon.